Hello everybody. Today I am going to talk about an infected preauricular sinus on the left side with recurrent abscess and how I excised it. I will show you the surgical steps. And this is, you can see, the preauricular sinus presenting in a 32-year-old lady. She had recurrent abscess. This is the abscess site which is present anteriorly, and the abscess was drained 2 times earlier. So now, starting the excision, first I will try to cannulate and find out the entire tract of the preauricular sinus. I'm using a Neoflon 24 gauge to identify the tract, and then by an elliptoid incision around the tract I begin my dissection. So the incision has to be given superficially, otherwise it will cut the tract. So after that, we're using the sharp scissors. I'm doing a dissection, identifying the tract here. The main cue, the main hint for a proper dissection and prevention of recurrence is that most of these tracts are adherent to the helix. So one has to find a plane between the perichondrium of the helix and whatever between that and the subcutaneous tissue, whatever soft tissue is there anterior to it. So that is actually the plane of dissection. So you stay flush to the helix, then we will not miss out the tract. So here I am dissecting the tract. I have already cannulated it with the Neoflon, so that will help in identifying the tract, but sometimes there will be multiple tracts, as was in this case. So now you can see that I am trying to dissect the area in front of the helix and also superficially where the tract is attached. So one has to be careful to remove all the soft tissue that is present in the subcutaneous area, because usually these preauricular sinuses will have multiple tracts, not a single tract. So here you can see, please note, as I'm cutting this with the scissors, I felt I accidentally opened up the tract, and you can see some cheesy debris from within the tract coming out. So that was a mistake I made here. And so this is a learning experience for all of us, that one should always stay flush to the helix. As you can see here, this is the correct plane of dissection, just anterior to the helix, and so that we do not miss out any part of the tract. And because of recurrent infection, there will be a lot of fibrosis and adhesions, so one cannot clearly delineate the tracts. So to be on the safe side, one has to dissect whatever tissue that is there superficial to the temporalis fascia, overlying the temporalis muscle, and also whatever tissue, subcutaneous tissue, is there anterior to the helix. If we do that, then there is no chance that there will be any residual tract left and recurrence of the preauricular sinus, because as I said that there will not be a single tract, there will be multiple branches, and one has to take out whatever branches are there. And the branches are not always clearly identified. The main tract will be identified, but the branches may be missed out because of the recurrent infection. So one has to take out whatever infected tissue is present just below the skin, and the depth should be up to this, whatever is tissue is there superficial to the temporalis fascia. If we do that, we ensure that all the tracts are removed in toto. So here you can see I'm dissecting anterior to the helix cartilage because the tracts are adherent to that, and which is the common finding in all cases of preauricular sinuses. But while doing that, one must be careful not to cut the cartilage of the helix and keep the perichondrium also intact to prevent future perichondritis. So in my case, the tract has been already amputated accidentally because I opened the tract. So you can see the residual part of the tract deep inside, and so I am excising that. So I'm using the monopolar cautery and carefully cutting the subcutaneous tissue, whatever is there. And this is the tract, part of the tract with the cheesy material from within, and the other half of the tract is lying deep inside. This is the part which I had accidentally opened, and the residual part which I am holding in the forceps. And deep inside in the field, you can see the appearance of the superficial temporal artery which lies anteriorly. So in dissection, one must be careful not to injure this artery. Once we identify it carefully, we have to stay superficial to that. And the skin and the subcutaneous tissue will be adherent to the tract also. So sometimes even that has to be removed, because that skin would have already become partly necrotic, that there will be a lot of unhealthy granulations and all adherent. So all that has to be excised along with the tract. So that was the area of the abscess. The tract was going up to that area. And posteriorly, of course, like I said, that excise just anterior to the helix. So whatever tissue is present, that has to be included in your dissection specimen, so that no part of the tract is mixed. This is a deeper part of the tract which you can see. So I'm using sharp scissors and also the monopolar needle, the Colorado needle, that is, you can use bipolar also. So main thing is one has to be careful not to injure the superficial temporal artery while dissecting. So this is a residual tract which I have removed, and now I will also excise the unhealthy skin around the previous abscess area, preauricular abscess, because this skin will not be viable, and I do not want the patient to have a bad scar post-operatively. So I am removed that unhealthy skin and the adjacent subcutaneous tissue. So I'll trim the edges to make neat margins, and that is the superficial temporal artery which you can see in the field pulsating. So as you can see that all the tissue has been removed and there is a clean field, and the helix cartilage can be seen with the perichondrium intact. So whatever tract was there was anterior to that. Now I have put some betadine and have just trimming the edges, irregular skin edges at the site of the previous abscess. Also some skin might need to be released to get a good apposition. We can put mattress sutures if we want, if there is a big skin defect. Otherwise, if the skin is usually very lax here, so normally we can approximate them without any problem, even though we have sacrificed a bit of the skin. So I'm using 40 Vicryl and taking deep bites, including the subcutaneous and the skin, and approximating the wound margins. So one has to do a pressure dressing here, or leave a small drain if you want. The pressure dressing will help in prevention of any hematoma post-operatively in the dead space, since you have excised a good bit of the tissue. And mastoid dressing is done, which is left for 1 week. 1 week course of antibiotics given. Patient asked to come after 1 week, after which the dressing is removed. So in this case, the skin healed well, the suture line healed well, and this is the tract which you can see, both the amputated part and the remaining residual part. There were 2 tracts which were clearly evident, and so the patient recovered well. 1 month after surgery, the patient is doing well. Thank you for watching.